a wonderful number of subjects and topics that we've discussed today. And this is the final session. My name is Richard Gralla. I will be chairing this session, and I will be giving the first talk. There is one change to the program. Unfortunately, Dr. Mortier will not be able to attend, and unfortunately, we will not have his lecture on melanoma that I was very much looking forward to. But I think we've done a pretty good job in having so many lectures here today. I will make a few comments about melanoma, but not so many then. We'll be talking about a variety of therapies, and following my presentation will be 3 speakers talking about interesting toxicities and ideas of management of those toxicities, which some of the newer therapies are changing some of what we do. There was talk in the last session about the fact that is there a reason that supportive care and all evidence-based therapies shouldn't be offered by all of us who treat cancer and or make available to our patients? And I think that's very, very true. And when we have new agents, we certainly need to look into the toxicities. And TAO as a history, under the wonderful guidance of Florian Scottet, has always looked at the most interesting ways of treating toxicities, preventing toxicities, and improving quality of life. Now, my topic is to address PD1, the PD1 pathway in lung cancer, and I will do that, but I think it needs to be put into proper context. I'm going to talk briefly about the newer approaches to treating lung cancer, non-small cell lung cancer, and I'll start with some things that are very old now, maybe 5, 6, 7, 8 years, and then look at some refining information that has come out this year, and then try to put the PD1 into context. And I hope this is of interest to you. We'll take questions after my presentation, and then we will have the next 3 presenters, and then we'll have a panel after that. So looking at newer approaches, this is not true just with lung cancer. This is true with almost all the malignancies that we see, and that is that we have chemotherapy. We have what we call molecularly targeted approaches because we don't really know a better way to have a term for these newer therapies, or perhaps both. And this is common. When we have our tumor boards and we discuss patients and cases, sit back and think what that discussion would have been like 5 or 10 years ago. It's much different. We're asking about molecular testing that we would not have been asking about before. We're looking at different sequences of treatments. This was a very interesting paper that was published in the year 2000 by Hanahan and Weinberg. And they looked at that time at new ways of approaching cancer, how cancer is different than the normal mammalian cell. And they've updated this, which I will refer to a little later. But how did they do? And you can see that there are several pathways that we talk about and that we have agents for that we did not have agents for in the year 2000. Well, one of the most successful of these are areas of growth signaling, signal transduction. And this is an area that's very important in molecularly targeted agents. And of the many different pathways, and this is an oversimplification, one of the areas in lung cancer that is most important in Asia and Europe and North America is the epidermal growth factor receptor, the EGFR receptor. We've all learned a great deal about it in the last few years. We knew that there are 2 particular areas that it turns out that the gene that codes for the receptor has 28 different exons, and that in the 6 exons or 8 exons that make up most of the portion that codes for the tyrosine kinase portion of the receptor. That's where mutations occur, and that's, of course, where the tyrosine kinase inhibitors have their effect. So there are 2 major mutations here. One, which is a deletion, a single nucleotide polymorphism deletion on exon 19, and one on exon 21, which is an amino acid substitution. If we find that there are mutations in those 2 locations, it means that the patient has a very good chance of responding to the tyrosine kinase inhibitors. Gefitinib or erlotinib are the classical ones for this. Now you can see on this cartoon the not only exon 19 and 21, but also exon 20, which I'll be referring to in just a little while. So erlotinib is used more in North America. Gefitinib is used more in Asia. And if you look at this interesting Canadian study that was really the licensing study, they showed as second line in a 2-to-1 randomization that patients who received erlotinib lived longer, a little bit longer, than those who did not, those who received placebo as second line. There was no real crossover here to erlotinib. The interesting thing about this is they found that the non-smoking patients, the curves on your left, lived much longer than those who received placebo. Now, this was the last trial. This was one of the first and was the last trial in which there was no crossover to this tyrosine kinase inhibitor. So if you take those never smokers, we expect that at least 50% and perhaps as high as 70% of those patients had the EGFR mutations on exon 19 or 21. And that's why they lived longer. So without the crossover on both arms to erlotinib, we actually do have a study that shows in an enriched population likely to have the mutation that they do in fact live longer, better survival and better PFS. So I want to share with you a meta-analysis that was presented at the lung cancer meetings a year ago and that's undergoing editorial review right now. And this is a meta-analysis only in patients who have these mutations, and particularly these 2 mutations that we talked about. And it's based on several thousand patients, almost 2,000 patients that were randomized. And do patients with exon 19 do better than those with exon 21? We suspect that's true. But what happens with other clinical factors? Do they make a difference? If you have the mutation, does it matter whether you're male or female? Does it matter whether you're a smoker or not? And here are the results. If you look at that top line, there is no doubt that if you have the mutation, one of those mutations, and you receive the tyrosine kinase inhibitor rather than chemotherapy, your PFS, progression-free survival, that hazard ratio shows a very major impact. Now, it's no longer possible really to look at survival here because over 90% of the patients cross over and receive the tyrosine kinase inhibitor. So that's why we don't see survival differences here. But it was not a surprise to us that the hazard ratio is only 0.25, a terrific number for the exon 19, but it's 0.48 for those patients who had the exon 21. So the exon 19 is a much better mutation to have. A surprise was that patients who are never smokers versus the unusual patient who's a smoker have a much better hazard ratio also, and women do better than men. All these patients benefit from having the tyrosine kinase inhibitor, but there are clinical factors as well as mutational factors that influence the progression-free survival. This could have an impact on whether you do a difficult biopsy to obtain tissue. So if it's a woman never smoker, that might influence you rather than a man who is a smoker, because the benefit for the man who's a smoker is going to be decidedly less than it would be for the other patient. Admittedly, the drug would be reasonable for both of them. We published in 2013 another meta-analysis, and these were the largest meta-analysis to tell us more about this. And the results of that large meta-analysis from randomized studies of mutation-positive and non-mutation patients said that established for the first time that getting these drugs either as first-line or second-line doesn't matter in terms of the magnitude of benefit. It's the same first and second line. That nearly all of the benefit is in those patients who have mutations. Patients who do not have mutations have such trivial benefit that it's hardly worth talking about. And that patients who are receiving the TKI plus chemo don't do better if they have mutations than those who have EGFR TKI alone. And the NCCN guidelines are conflicted and confused by that, but the evidence says just the TKI does as well as the two together. So again, we found the mutational information, the clinical ones that I mentioned to you. But these patients are not cured by these drugs and they become resistant. And the resistance pathways are fairly well known now. About 70% of the patients will develop during therapy the presence of a mutation on exon 20, and that's the T790M. So we know this is the main resistance pathway. There are others, but it looks like MET amplification is less than we expected. So obviously, a great strategy is to develop agents that are directed at this resistance pathway. And if you look at the CO1686, that is an investigational drug. The other two drugs are not investigational. And you can see on the bottom row that it has particularly strong target affinity for the T790M mutated patients. All of these drugs work in the EGFR, the usual EGFR mutation, but in the EGFR wild type, you do not want to influence that pathway because that's toxicity, that's not benefit. So does CO1686 and two other drugs work for the patients who have this T790M, which is an unusual patient, but it still happens? And do you get less toxicity? So here is a phase 1-2 study, 40 patients with demonstrated T790M resistance with the mutation there. And as you can see, in these 40 patients, the response rate is 58%, really an amazing response in second-line non-small cell lung cancer. And if you like waterfall plots, you can see that almost everybody had some degree of benefit. What about toxicities? And if you look at toxicities here, the three lower drugs are like CO1686, that is, they're particularly addressed at this mutational pathway. And they are particularly do not have much affinity for the wild type. And you can see that their diarrhea is much less than the more classical agents, and skin rashes also. So it is possible that these agents may address a need that we have, resistance, and may do so with less toxicity because of less involvement. Now, we have some of our older drugs like sunitinib that hit many different pathways, but in fact, that may not be the best strategy. Our patients typically have one activating pathway, and hitting that activating pathway while it's still relevant may produce fewer toxicities and hopefully more benefit. But almost all of these mutations are in non-smokers. And if you look at the whole pie of people who have lung cancer, only 15 to 20% are non-smokers. So we are not addressing the patients who are smokers who make up the majority of patients with lung cancer. Another target among these patients, largely with adenocarcinoma and largely non-smokers, is a genetic change, but it's not a mutation most of the time. It's a rearrangement, the EML4 ALK, which can involve in North American and Europeans up to 25% of those with mutations. So this occurs again almost exclusively, not entirely, in never smokers, and it is a rearrangement. It's an amazing story that the first publication showing the fact that this existed in lung cancer was in 2007, and by 2011, crizotinib, the drug for this, was approved. And this year, in 2 countries, we've had approval of another drug, ceritinib, for patients who have acquired resistance. So this has been quite the rapid progression of development of such agents. If we look at crizotinib in its initial studies, the response rate was 57%. That's just amazing. I don't know that we need a waterfall plot when we have a 57% response rate. But unfortunately, this makes up only 4 or 5% of all patients with non-small cell lung cancer. We had last year in the New England Journal of Medicine a second-line versus chemotherapy, and of course the progression-free survival favored the crizotinib with quite a nice hazard ratio of 0.49. And we had this year presented at ASCO a first-line evaluation of crizotinib versus chemotherapy. And again, we see here quite a large hazard ratio benefit as first-line therapy, again, in those patients who have at least 15% of their cells show this rearrangement. Now, let's go back to the hallmarks of cancer again. Dr. Weinberg and Drs. Weinberg and Hanahan have updated this in a 2011 publication, which makes for interesting reading. And one of the things that they look at, again, is the tissue invasion and metastasis, especially looking at immune pathways and immune suppression. Okay, and this is where the Pd1 was not really so anticipated going back a decade. So what we know is that the microenvironment is very important with the tumor cell. We know that most transformed cells are picked up by immune surveillance and are eliminated. But unfortunately, some cells are not eliminated, and it looks as though some cancer cells are able to induce immune suppression in their own environment, thus allowing them to grow. So this is a mechanism by which we get proliferation and establishment of cancer. Tissue invasion in the microenvironment, and then growth, and then metastasis. Now, again, all these mutations that are of interest are in non-smokers. The Pd1, or programmed death protein 1, colorful name, does not appear to favor patients who are non-smokers and does not appear to favor patients with adenocarcinoma. So instead of being targeted for 10 or 20% of the patients, it may be targeting the 80% with non-small cell lung cancer. Not every patient, but indeed patients within that group. So what we have is this. The blue cell in this cartoon is the cytotoxic T lymphocyte. It identifies tumor cells from the cell's major histocompatibility complex. So if that links to the T cell receptor, you then get some recognition of the tumor cell. But the tumor cell then, by its linkage to the major histocompatibility complex, induces upregulation through various cytokines such as tumor necrosis factor alpha, such as interferon, upregulates PD-L1, the ligand for PD-1. Now, PD-1's function is to inhibit cytokine production, to inhibit cytolytic function of the T lymphocyte, and to inhibit T cell proliferation. So by doing that, you then inhibit the killing of the tumor cell by the natural immunity systems that we have. So you upregulate on the cartoon, on the tumor cell surface, PDL1, the ligand for PD1. So once that happens, and once you have the linkage of the PD1 and the PDL1, the lymphocyte then recognizes the tumor cell as self and does not destroy it. So by upregulating PDL1, the tumor cell influences its microenvironment. If you can block this linkage, you can restore the lymphocyte to its cytotoxic cytolytic function. So that's the mechanism of the anti-PDL1 approach. So the targets are either PD1 on the T cell or PDL1 on the tumor cell. And so there are monoclonal antibodies that are now that have been made and are largely investigational to see if these approaches will actually work. Now, you may be familiar, and you can see on this cartoon, the cytotoxic T lymphocyte 4, for which ipilimumab has been approved a few years ago for the treatment of melanoma, and it works in a fairly similar pathway to restore the immune function of the T lymphocytes. This is a related but separate impact. And so if we look at the drugs that are most used, you can see them listed here. Interesting, pembrolizumab is an anti-PD1 monoclonal antibody that has been approved in the US for metastatic melanoma just in the last few weeks, and pembrolizumab is also available, I understand, through an expanded access program for metastatic melanoma in France. Again, this is for patients who do not overexpress BRAF. And nivolumab is also a drug for which there are many studies. Lung cancer was not expected to be an immunogenic tumor. Melanoma has for years been expected to be a very immunogenic tumor, but not lung cancer. So to see activity in a cancer such as lung cancer is very interesting. So these are all studies. You can see the number of patients varies from 40 to 200, that the response rates vary from 15 to 25%, and that's monotherapy of these monoclonals in patients with lung cancer. For most patients, the progression-free survival has been quite long for most patients who respond. And this is really something that is very fascinating and perhaps not as well understood as it should be. Now, we have several trials in melanoma, not my area that I'm going to talk about. For nivolumab, there was just published from Dr. Robert at the Institut Gustave Roussy, a study comparing nivolumab to dacarbazine in malignant melanoma, and there was better PFS and better survival in those patients receiving the anti-PD1 approach. So the results are getting richer, and the responses are getting increasingly interesting. Let's look at the toxicity. Here's the toxicity pattern of pembrolizumab in lung cancer patients that was presented at ASCO this year. It's a small number of patients, but if you look at any of those toxicities, these are incidents of any grade occurring in more than 5% of patients, that's lower than we expect with most of the molecularly targeted drugs. And that's really interesting. The toxicities are less than those seen with ipilimumab, and that's important. If we look at those patients who had grade 3 and 4 adverse events, we see only a few. It does appear that the pneumonitis is real and can be fatal. We know we've seen that with the tyrosine kinase inhibitors in lung cancer, and so it's of concern. It's not common. It may be that the mechanism is that the anti-PD1 antibody also interacts with the anti-PD2 pathway, and the PD2 pathway is expressed in normal lung. So that may be the mechanism where it can occur. We need to work on all of these toxicities, and we need to be having better answers. And I think for the lung, we need to understand the toxicity better. Well, if PD1, if PDL1 is what binds to PD1, and if PDL1 expression implies a worse prognosis, which it appears to for several tumors, can we see if the tissue expresses PDL1 and if that implies response? Well, you can see the 4 drugs that I showed you before, and if you look at the bottom, we'll look at nivolumab first. The cut point, meaning that 1% of the patients expressed, of the cells expressed the PD1, or 5% in second line. And you can see in the 2 bottom rows, this is the response rate if they were PD-L1 positive, and this is if they're negative. And you get a hint that maybe something's going on in the first line, but not in the second line. And so it's not clear. If you look at pembrolizumab, well, you see in the second line something close, maybe something's going on. Here, look when they looked for 50% of the cells, but that was the minority of patients. When you look at the Genentech Roche drug, you see there seems to be a favoritism, but the numbers are so small. And in the MedImmune drug, again, the numbers are very small. So the jury is still out as to whether PD-L1 will be a useful marker to imply that patients will respond. But of course, it would be quite interesting. We also know that the PD-L1 expression, just from what I showed you, can be dynamic depending what is happening in the microenvironment. So this could influence what happens to the assay. So to conclude on the PD1 and PD-L1, that we have several agents and we have a consistent response in a very difficult tumor of 15 to 25% with fairly well-tolerated monoclonal antibodies. That for the first time we have an agent that does not favor non-smokers necessarily or adenocarcinoma, so it may be better for a broad spectrum of patients. It's not clear yet if the PD-L1 overexpression is a predictor of anti-tumor activity, but I think it will be important to look at that. And it is not clear whether interfering with this pathway by blocking the PD-L1 or the PD-1 may be superior in terms of either efficacy or toxicity. But the time is early, and this is an extremely exciting pathway. Still in lung cancer, the relative reduction of the risk of death is simply by treating the patient. First and second line treatment with chemotherapy provides the biggest benefit. The way you give the chemotherapy, how you choose the agents has a lesser effect, but it has an effect. And really, if we look at the whole spectrum of lung cancer patients, the molecularly targeted agents affect individuals rather well, but the whole lung cancer problem not so much. But the times are early. We now have at least 3 distinct treatment strategies in treating this very difficult cancer of lung cancer. We have chemotherapy. We have the genetic abnormalities such as the EGFR and the EML-ALK, ROS1, and other genetic abnormalities. And then we have the immune checkpoint inhibition by the PD-1 pathway. We were just talking during the break that 5 years ago, not one of us would have suspected we would have had this pathway. Is there any reason to believe that these are the only 3 pathways that we're going to have? Not at all. And I think this is extremely invigorating and optimistic to see different ways to be able to personalize treatment for different patients. Newer pathways have the potential to identify individuals who are likely to respond. Chemotherapy is still important. Much research focuses on resistance pathways, which is great. And toxicity profiles vary. We're going to talk about those the next few speakers. But this needs to be something that we do because, as the MASK motto says, good supportive care makes excellent cancer care possible. And I see no reason to suspect that there's only 3 distinct pathways. And of course, the Pd1, which has been looked at the most in melanoma, next most in non-small cell, there's no reason that this pathway should be limited to just those 2 drugs. Thank you very much.